Hi everyone, I'm Dr. Basili, your orthopedics faculty with Marrow. In this session, I want to review all the questions that were asked in the NEET-PG 2025 that was conducted in August, the orthopedic questions most importantly. And I will tell you what kind of paper it was in terms of orthopedics and how you need to, tweak your preparation if you have to. I'll not be wasting a lot of your time. I just want you to understand the concept behind the question so that if the question is asked again in a different combination of options and scenarios, you should be able to answer it. Yet again, it is proven that diagnosis is the standard thing that you should remember about all the conditions and the diseases, how to make the diagnosis. And once you've made the diagnosis, you should know what is the treatment, what is the investigation, what are the complications. And again, it has been proved that you cannot answer these questions without knowing the diagnosis. So this is the scenario of the exam. The true orthopedic questions were roughly around 8 questions. There were a few overlaps from anatomy, 2 to 3 questions. So you can say pure orthopedic questions were 8 questions. Standard topics like metabolic bone diseases had 1. Trauma, yet again, very important, 2 questions. Pediatric ortho, 1 question. Spine, 1 question. Sports injury, this was surprising this time, there was a question. And joint disorder. See, none of the topics are new. All of these are standard topics, and the questions that were asked are again from standard subsets of those topics or standard conditions. Now, the ones that are marked with this asterisk are the ones that were asked the last 6 months to 1 year, very recently asked questions in the NEET-PG and INA-SET exam. Yet again, it tells us that we should be confident and we should be well aware of the recently asked questions of any exam in the medical stream, whether it's INA-SET, NEET-PG or FMG screening exam. Nevertheless, so our objective here is to review the question, possible question, and the options and try to answer them. The objective is not to measure how we scored or what we scored. The objective here is to understand how they ask these questions. So even though you're familiar with these topics, you should know how they can twist the options to trick you. Okay. So this is the first question. A 20-year-old man presents with chronic back pain. This was worse in the morning and reduces with physical activity within 1.5 hours or 1.5 hours. History of anterior uveitis. An X-ray of the sacroiliac joint was normal. On examination, lumbar lordosis was lost and spinal flexion was reduced. What is the diagnostic modality for early diagnosis of this condition? Options are CT of sacroiliac joint, MRI of sacroiliac joint, anti-CCP, X-ray of dorso-lumbar spine. Now, how do you approach this question? This is a classical clinical question. The approach of this question is very straightforward, very simple, if you know how to approach it. The approach is first you need to make the diagnosis. So information is provided. You need to come to a reasonable diagnosis. Once you have established the diagnosis, then the question is asking, what is the diagnostic modality for the early diagnosis of this condition? And then you have to see which diagnostic modality will you be able to use to make a early diagnosis of this condition that you have just clinically diagnosed. Are you understanding? Right. So what do you imagine is the diagnosis? If you miss the diagnosis, your answer will become wrong. So the diagnosis here is very straightforward. It is ankylosing spondylitis. Now, how do you may ask? Because it's a 20-year-old man, young man, back pain, right? With morning stiffness, that is worse in the morning and reduces with physical activity. So this is classical morning stiffness. Anterior uveitis, pointing more towards ankylosing spondylitis. X-ray of the sacroiliac joint is normal. X-ray of the SI joint is normal. This is an essential criteria to make a diagnosis of ankylosing spondylitis is sacroiliitis. It is normal here, but it is early on in the disease. There is examination of lumbar lordosis, which shows lost lumbar lordosis and restriction or reduced spinal flexion, means patient is unable to flex the spine. So there is fusion of the spine. So ankylosis is happening. So diagnosis is ankylosing spondylitis. Now, once you've made the diagnosis, the question is asking, what is the diagnostic modality that will help you make the early diagnosis? Is it anti-CCP? No, it cannot be anti-CCP. Why? Because anti-CCP is used to diagnose rheumatoid arthritis. So this is not the answer. X-ray of dorsolumbar spine. See, sacroiliac joint. X-ray is normal. So what is X-ray of the dorsolumbar spine going to help you? X-ray changes appear later. So no. Now CT of the sacroiliac joint or MRI of the sacroiliac joint? If you recall from the regular videos, I've told you specifically, MRI picks up changes earliest. So MRI of the sacroiliac joint is the answer of this question. Are you understanding? That is how you approach this question. Now, for quick review of how we came to the diagnosis of ankylosing spondylitis and why it is not rheumatoid arthritis, just look at this. Spondyloarthropathies, it's a group of conditions which involves the spine and the joints. Right? These are seronegative, means their rheumatoid factor is negative. So it has nothing to do with rheumatoid arthritis. This usually occurs in young males who are HLA-B27 positive and also have eye condition like anterior uveitis. What are the group of conditions? Ankylosing spondylitis is the most common spondyloarthropathy. Others are psoriatic arthritis and all of these. Similarly, ankylosing spondylitis occurs in male, HLA-B27 positive, and involves the axial spine more than the peripheral spine. And which joint is the most common joint involved? Sacroiliac joint. The other axial parts are spine and hip joint. What is the pathology? Enthesopathy, which is nothing but inflammation of enthesis sites of attachment of ligaments and tendons, which leads to inflammation and calcification. That is why it leads to fusion. Patient complains of morning stiffness. Morning stiffness is a feature of inflammatory arthritis. All types of inflammatory arthritis. And there is decreased lumbar spine movement. Spine movement is restricted because of pain and fusion. Decreased chest expansion also, and there is anterior uveitis. What is the essential criteria to make the diagnosis of ankylosing spondylitis? Sacroiliitis, and it's clearly mentioned in our notes and video that the earliest changes are picked up on MRI. Earliest changes are picked up on MRI. And more importantly, the changes will be noticed on the iliac side more than the sacral side. Supportive criteria are decreased lumbar spine movement, decreased chest expansion, and inflammatory back pain. This is an X-ray of a normal individual, and this is an X-ray of a patient who has sacroiliitis, which is evident on X-ray. Usually, early changes it is not visible on X-ray. That is why you get an MRI. Fusion of the vertebra, that is what causes your bamboo spine and restriction of lumbar spine movement. Bamboo spine and restriction of lumbar spine movement. And for that, we have a clinical test known as Schober's test and modified Schober's test, where you measure the distance between 2 points of the lumbar spine and ask the patient to bend forward. Normally, if your lumbar spine is flexible, on bending forward, the length increases. This length increases, but because in these patients there is fusion of the lumbosacral spine, the patient on bending forward, the distance does not increase. This is known as Schober's and modified Schober's test. In contrast, rheumatoid arthritis usually involves females and they have symmetrical peripheral joint involvement, small joints of the hand and feet. Axial skeleton is rarely involved, and if it involved, it is usually the cervical spine, not the lumbar spine. And two important parameters for rheumatoid arthritis is rheumatoid factor is positive, that is the most sensitive marker, and the most specific marker is anti-CCP. That is why anti-CCP was not the answer. I hope I'm clear with this question. Approach the question, clinical question, reach the diagnosis, and once you have the diagnosis, then you can answer the question, whether it is in terms of investigation, whether it's in terms of treatment or complications. Now look at the second question. Again, it's a diagnosis-based question. An 8-year-old boy has been limping painlessly for 10 months. Given the provided X-ray, what is the probable diagnosis? Perthes disease, DDH, that is developmental dysplasia of hip, TB hip, that is tuberculosis of the hip, and SCFE, that is slipped capital femoral epiphysis. So there are a few things that you should know here. You should know the acronym SCFE, you should know the acronym DDH, otherwise you wouldn't know the word that is there in the option, even though you must have read the topic. So here is an X-ray provided. This question you can actually answer without the X-ray also. So it's an 8-year-old boy limping painlessly. Right? These words, 8-year-old boy, painless limp. These words must have been resonating in your head because we have taught this in our regular videos. Right? So what is the X-ray showing you? It's an X-ray of a pelvis with both the hips of a young child, right? Because the growth plates are visible and the acetabulum is still not completely fused, striated cartilage still there. And also one head of the femur looks normal. The other is fragmented over here. Other looks like fragmented head of the femur. Without the X-ray, you can make the diagnosis based on the keywords that are given. But with the X-ray, it is even more easy. What is the answer? The answer is Perthes disease? Perthes disease. See, you can still answer this by ruling out a few options. First of all, painless limb. Painless limb. If you think of painless limb, what are the options you can rule out? You can rule out skiffy because it is painful. It is a break. It's a break, right? Slipping of the capital femoral epiphysis, right? TB hip, yes, it is an infection, so it must be painful. There is arthritis, right? Tubercular arthritis. Now, DDH and Perthes, these are two conditions that are relatively painless. They are painless. But DDH, the presentation is since birth or a few weeks after birth. But Perthes disease classically presents between 6 to 10 years. So the diagnosis here is Perthes disease, right? So quickly first review that we can make the diagnosis with the history in the question. We can also make the diagnosis with the X-ray provided. So this is a normal X-ray of the pelvis with both hips of a child. To make the diagnosis of DDH on X-ray, what were the lines I taught you to draw? Two important lines. One horizontal line from the centers of the triradiate cartilage, that is known as the Hilgen-Riener's line, and two perpendicular lines that you draw at the lateral margin of the acetabulum. Perkins line. And this divides each hip into 4 quadrants, 2 upper, 2 lower, 2 upper, and 2 lower. Normal head of the femur should be in the inner and lower quadrant. But in DDH, it will be in the upper and outer quadrant. So this is a clear radiological diagnosis of DDH. But our image is not DDH, because here if you draw those lines, the head of the femur is predominantly in the inner and lower quadrant. So not DDH. What is it? It is basically your Perthes disease. How and all we'll discuss now. So Hilgen-Riener's line, Perkins line, I've taught you that also. Now what about this? Perthes versus Skiffy. How do you differentiate Perthes and Skiffy? Both are acquired types of coxa, right? Both are acquired types of coxa. What is the difference? In Skiffy, there is slipping of the capital femoral epiphysis. So there is actually a break or a fracture, slipping of capital femoral epiphysis. Why does it occur? Because of endocrine abnormality, growth hormone, and sex hormone that we have discussed. So it must occur in pre-pubertal or pubertal children. Whereas the Skiffy is because of compromised blood supply during the bridge phase, during the development. We'll discuss how that happens. So here you are noticing fragmentation of the head of the femur. Here you are noticing there is a separation of the capital femoral epiphysis. So X-ray for Skiffy would look something like this, and X-ray of Perthes is this. Our image is Perthes, classical Perthes. Right. Anyways, so recall yourself, Skiffy. What were the keywords for Skiffy? Pre-pubertal, peripubertal, pre or peripubertal, just around the puberty time, males and females. Because of endocrine abnormality, the growth plate does not fuse. Growth spurt happens, leads to breach in the growth plate, separating the capital femoral epiphysis from the neck of the femur. And there was one radiological sign that you could do, na? Treth-Hoven sign. What was that Treth-Hoven sign? If you draw a line along the neck of the femur, it will not intersect the head or the capital femoral epiphysis on the affected side. So look at this. This is the normal side. If you draw a line, it will intersect the head of the femur. This is normal. But in Skiffy, if you draw a line, it does not intersect the head of the femur. This is known as Treth-Hoven sign, and this line is Klein's line. So this is something what you would have seen in a patient of Skiffy. Whereas Perthes disease, what is it? Also known as coxa plana, leg Perthes disease. It is idiopathic. It is idiopathic osteochondritis of the femoral epiphysis. Why does it occur? It occurs because of compromised blood supply. And why is there compromised blood supply? Because in childhood, the head of the femur receives blood supply from the foveolar artery, and as the child grows, it receives from the metaphyseal source. So foveolar source and metaphyseal source. But there is a transition. In very early age, that is less than 4 years, it is predominantly foveolar supply. And as the child grows, it becomes predominantly metaphyseal. So between this early and late phase, we call it the bridge phase. So during this bridge phase, between 4 to 10 years, the head of the femur gets compromised blood supply. Because transition is happening, so head of the femur does not get the blood supply. So during this age group, there is ischemia of the capital femoral epiphysis. And this ischemia leads to necrosis and fragmentation. And that is what causes Perthes disease. Initially, this causes limp in the child, and it is a painless limp. And later, eventually, it might become painful. But the word painless limp is usually associated with Perthes disease. So, cause is idiopathic, mostly in males during the bridge phase between 4 to 10 years. So, roughly around 6 to 8 years is the predominant age group. Painless limp can be painful later in life. So, patient has limitation of hip movement, cannot sit cross-legged, cannot squat. Investigation of choices, MRI, because X-ray changes usually are visible late. So friends, before I close this MCQ, I want to give you an approach to a child with limp, right? Suppose a child comes to you with a limp. What are the possible diagnoses that you can think of? You can think of Perthes 1, right? You can think of SCFE. You can think of developmental dysplasia of hip. You can also think of transient synovitis. You can also think of septic arthritis. And you can also think of a fracture or dislocation. You can think of all of these things, right? Child has a limp, all of these things are there. But there will be a few points that will help you rule out the options. See, if there is a fracture or dislocation, there will always be history of trauma, child falling from a height or something like that, significant trauma. So you can rule this out based on the history of trauma. For septic arthritis, obviously patient will have high fever, elevated ESR, CRP, WBC count, tense swelling at the hip. Septic arthritis, that is how you can rule it out. What about transient synovitis? Now, transient synovitis is slightly tricky. All right, it is a diagnosis of exclusion. Here, the patient will have some synovitis, so some collection at the hip joint, but no high-grade fever, no elevation of significant WBCs or ESR or CRPs. Maybe mild to moderate elevation, right? So that is transient synovitis. Now, Perthes and SCFE and DDH. Painless, Perthes and DDH. How do you differentiate between them? DDH, since birth or a few weeks after birth. Perthes, around 6 to 8 years. And what about SCFE? SCFE will be painful, peripubertal children with endocrine abnormality. If you think of these things, nobody will have any problem approaching these kind of questions. Okay? Right. So next question. A 65-year-old man presents with bony lesion in the lower limb. He also gives a history of an increase in hat size. On examination, bones feel warm to touch and bowing of legs is present. X-ray showed mixed lytic sclerotic bone lesion. Mixed lytic sclerotic bone lesion. ALP levels are 250 international units per liter. But there is normal serum calcium, phosphate, PTH. What is the most likely diagnosis? Is it osteomalacia, Paget's disease, primary hyperparathyroidism, metastatic disease of the bone? If you have watched the videos, I have taught you the exact scenario to approach such questions, right? Very straightforward, and keywords are mentioned, lab evidence is given, clinical features are given. All of them are straightforward, pointing towards Paget's disease of the bone. Now, if you have not got the answer, there is still a way to rule them out easily. How? How can you rule it out? What is osteomalacia? It's a mineralization defect. So there is a deficiency of the calcium, right? There is elevation of PTH. And because of that, phosphate will be decreased. But here, all of these are normal. So it cannot be osteomalacia. In primary hyperparathyroidism, what happens? There is an adenoma of the parathyroid gland, which is excessively secreting PTH. So PTH will be high, very, very high. And when there is excessive secretion of PTH, there will be excessive absorption of calcium. So calcium will be high and phosphate will be excreted. So here, calcium high, PTH high. But here, calcium and phosphate are, PTH are all normal. So it cannot be primary hyperparathyroidism also. What about metastatic disease of the bone? Quite possibly, yes. Metastatic disease of the bone, yes. Metastasis from certain tumors, say like prostate, medulloblastoma, carcinoids. They are osteoblastic mets. Right? So they can increase ALP. But apart from that, patients with a metastatic disease will have other problems also, like say liver failure, kidney failure, anemia, all of those things will be there. Here, the patient was not complaining of anything. Instead, the patient has an increased hat size, history of increase in hat size. Bones are warm to touch. Warm to touch means bones are very vascular. And what else? What else? Very, very important. Mixed lytic and sclerotic bone lesion. All pointing towards Paget's disease, because Paget's disease divided into 3 stages for simplicity of understanding. Lytic, mixed, and plastic phase, right? The 3 stages, right? They don't occur step by step like that, but overall it's a mosaic pattern, and all of that is seen in a similar bone, and this causes increased thickness of the bone, warm bone, very vascular bone, and weak bone, leading to these bendings of bones, banana fracture, and such. And this thickness, if it occurs in the skull, you'll get your Tam or Shanter skull. Are you understanding? So, very classic clinical scenario. In our videos, we have discussed this approach to all metabolic bone disease questions. If there is a metabolic bone disease questions, look at where the problem is. Bone is divided into mineral part, the collagenous proteinaceous part, the cellular part. If the disease is involving the mineral part of the bone, so calcium, phosphate, PTH will be affected on the patient's labs. And if that is the case, the diagnosis will be limited to your hyperparathyroid problem, rickets, or osteomalacia, that is vitamin D problems. If the mineral part is normal, think of the collagen problem. Either the collagen is genetically abnormal, that is the collagen is genetically abnormal, collagen E1 gene defect, osteogenesis imperfecta, problem will be there. Intrauterine on antenatal scan, there will be multiple fractures. If the child is born, the child will have blue sclera. If the problem is deficiency of maturation of collagen, that is because of defect in or a deficiency of vitamin C, that is scurvy. Here the problem will occur later, not at the time of the birth, later. And here the problem will be easy bruising, bleeding comes and such. If the problem is neither collagen nor mineral, then it could be a cellular problem. Cells are osteoblasts and osteoclasts. Usually osteoblasts are not problematic. It is osteoclasts that are problematic. Excessively active osteoclast, excessive bone resorption, Paget's disease of the bone. Bone resorption leads to bone formation, ALP is elevated. And if osteoclasts are not functioning at all, so there is no resorption at all, bone is being formed, marble bone disease, osteopetrosis. And if the problem is not in the quality of the bone, but overall quantity of the bone is not being formed properly, the quantity of the bone is less, then it is your osteoporosis, where your labs are pretty much normal. This is the crux of approach to your metabolic bone diseases. So review Paget's disease, also known as osteitis deformans, occurs in males, elderly males like our patients. Most common cause is idiopathic. The disease is divided into lytic, mixed, and blastic phase. Labs are usually normal, except ALP, which is significantly high. Normal ALP is in the range of, say, 50 to 150 international units per liter. Here in this patient, it was 250, so quite high. And most of the times, patients with Paget's disease have very high ALP, somewhere around 900 also. Clinical features: pain, warm to touch bones, thickened, irregular. Patients has fracture, banana fracture, cranial nerve compression because stenosis of the cranial foramen, otosclerosis, thickening of the skull, that is known as Tam o Shanter skull. Tam o Shanter skull. And because of this thickening of the skull, patient will have to keep on changing the hat because it is not fitting his head properly. Okay. Now, the next question is a pretty straightforward spotter-based question. A 68-year-old female presents with chronic lower back pain. The X-ray spine is as follows. What is the diagnosis? Spondylolysis, spondylolisthesis, triple fail syndrome, or crushed vertebra? And how did I teach you to approach such question? Just follow the posterior wall of the vertebra and draw a line. And you will notice a step here. So there is a slipping of one vertebra over another. This is your spondylolisthesis. Direct repeat from the previous exam. This is spondylolisthesis. Most common location is L5, S1, slipping of one vertebra over another. What is spondylolysis? Spondylolysis is breach in the pars intra-articularis. Breach or fracture of the pars intra-articularis, and the radiological sign is Scottish dog or Scottish terrier with a collar sign. And because of this, if the vertebrae starts to slip, we call it spondylolisthesis. We call it spondylolisthesis. So spondylolysis, Scotty dog sign, and spondylolisthesis. Clinically, when you examine the patient, you will feel a step sign. This is known as step sign because there is slipping of the vertebrae. Okay. Now, next question I think is pretty straightforward. I'm hoping all of you got it right. We have been talking about this multiple times throughout our regular videos and revision videos. A male comes to the casualty after an RTA, road traffic accident, with a mid-shaft fracture of the femur and undergoes surgery. In wards, 2 days later, the patient presented with breathlessness, tachycardia, confusion, and petechial rashes over the chest and with the conjunctival hemorrhage. What is the probable diagnosis? DIC, sepsis, fat embolism syndrome, pulmonary embolism, right? Young adult, road traffic accident, femur fracture or long bone fracture, presenting to you with the triad of respiratory symptoms, central nervous system symptoms, and cutaneous symptoms. Petechial rashes, confusion, delirium, coma, difficulty breathing, tachypnea, dyspnea, breathlessness. This combination of these three things. What is your answer? It is fat embolism syndrome. Nothing else. This is fat embolism syndrome. But sir, some us after surgery, this doesn't matter. Before surgery, intra-op, post-op, there is always a risk of fat embolism syndrome. So the answer here is fat embolism syndrome. The triad of respiratory, neurological, and petechial rashes does not confuse. Does not confuse. If there is confusion and you cannot make the diagnosis, you can employ Gert's criteria to make the diagnosis. Treatment is just prevention and fixation of the fracture as soon as possible to prevent further dislodgement of the fat globules from the medullary cavity. Last point is, remember the keywords. These keywords will help you answer the question. Pain on passive stretch, or pain disproportionate to the fracture, or disproportionate to the clinical presentation. Compartment syndrome. If there is a history of massage, word massage is mentioned, myositis ossificans, and long bone fracture, particularly femur fracture, followed by difficulty breathing, petechial rashes, and central nervous system symptoms, you have to think of fat embolism syndrome. Very good. Next, a 20-year-old male athlete, while playing football, has an eversion injury. Which ligament is most commonly injured? Anterior talofibular ligament, posterior talofibular ligament, deltoid ligament, calcaneofibular ligament. See, eversion is something you should know. Only then you will be able to answer this question. Eversion and inversion. See, most commonly, whenever there is an injury to the ankle, whenever there is an ankle sprain, there is an inversion injury. And that inversion injury leads to injury to the anterior talofibular ligament, which is the most commonly injured ligament. But here the question is asking about eversion injury, which is not quite common. But if eversion injury does occur, it will lead to injury to the medial ligaments of the ankle, and the medial ligaments are known as deltoid ligament. Is that clear? So inversion is basically your foot going inwards, and eversion is your foot going outwards at the ankle. Foot going inwards is inversion, foot going outwards is eversion. So now, when the foot goes inward, which side is getting stretched? The lateral side is getting stretched. So lateral ligaments will be torn. So inversion injury, lateral ligaments will be torn. The most commonly torn is anterior talofibular. It goes from the talus to fibula. I'll show you that. So name has fibula. But when there is an eversion injury, the medial ligaments will be injured. So medial ligaments will have tibular word in it, not fibular. The combination of those tibular ligaments are known as deltoid ligaments. So what are the medial ligaments? You have anterior tibiocalcaneal, posterior tibiocalcaneal, right? Tibionavicular, anterior tibiotalar. So tibia, medial side. So these are the ligaments. This combination of ligaments are known as deltoid ligaments. These will be injured on eversion injury. Whereas lateral ligaments have fibular in it. Fibular. Everything is fibula, anterior talofibular, posterior talofibular, right? Fibular in posterior, lateral ligaments. So inversion injury, lateral ligaments are injured. Eversion injury, medial ligaments are injured. Most commonly, it is an inversion injury leading to injury to the anterior talofibular ligament. But the question asked about eversion injury. Now, if the question had asked about inversion injury, some of you are suggesting, then the answer would have been anterior talofibular ligament. So based on the question, you have to answer. Now, another straightforward question, I'm hoping all of you got it right. A 30-year-old man presents to the emergency department following a motorbike accident and is found to have a closed fracture of the shaft of the tibia. 6 hours later, he develops severe leg pain, which was not relieved by analgesics and worsened on passive dorsiflexion of the foot. On examination, sensations over the first dorsal web space were lost, but dorsalis pedis pulsations were present. What is the next step in management? Apply the cast and follow-up, emergency fasciotomy, elevate the limb and give opioid analgesics, CT angiography. Friends, what is the diagnosis? The diagnosis is compartment syndrome. How can you say it's compartment syndrome? 2 very important findings. Tibia fracture, most commonly occurs in the leg, right? Followed by tibia fracture, followed by severe pain. It's not relieved by analgesic and worsened on passive dorsiflexion. So pain on passive stretching, passive dorsiflexion aggravated the pain. Now, sensations are lost. Sensations are lost, meaning nerves getting compressed. So there is neuropathy now because of compression. But dorsalis pedis pulsations are present. Pulsations are good. But does pulse have any role in the diagnosis of compartment syndrome? No. So don't let that confuse you. Present pulse does not mean you have ruled out compartment syndrome. No, pulse is least important in the diagnosis of compartment syndrome. So this is a patient in compartment syndrome where there is neuropathy because of compression. What should you do? You should immediately decompress the compartment with emergency fasciotomy. This is a standard question. I'm sure all of you have answered it. Just review. The most important clinical feature is pain on passive stretching. And the least important is pulse. Others are puffiness, pallor, paresthesia, and paralysis. Objective diagnosis made by measurement of the compartment pressure. Less than 10 is normal. If it is more than 30, it is compartment syndrome established. Anything in the middle is compartment syndrome in evolution. How do you measure it? With a manometer. What is the treatment? Immediate fasciotomy, emergency fasciotomy. Do not waste your time. It is a clinical diagnosis. Immediate treatment will salvage the limb. Few more points. What is the most common cause of compartment syndrome? It is a fracture of the tibia. It occurs in the leg. But in children, supracondylar humerus fracture causing compartment syndrome of the forearm. And what is the most common cause of Volkmann ischemic contracture or Volkmann ischemia in children? It is supracondylar humerus fracture involving the forearm. And again, the keywords that you should not forget are pain on passive stretch, compartment syndrome, history of massage, myositis ossificans, long bone fracture, followed by three things: difficulty breathing, CNS symptoms, and petechial rashes. You're thinking of fat embolism syndrome. Next question, very straightforward, easy. I'm sure you will be able to answer this. Elderly patient presents with painful right knee with no history of trauma. So trauma is ruled out. On synovial fluid analysis, there is rhomboid-shaped crystals seen and positive birefringence on polarized light. Which of the following is the likely cause? Rheumatoid arthritis, gout, pseudogout, osteoarthritis. You've been reading about this since first year of your MBBS in biochemistry. Synovial fluid analysis showing crystals, so crystal deposition disease, a positive birefringence, polygonal in shaped. What is it? Positively birefringence, polygonal in shape. Pseudogout, right? The answer is pseudogout. What happens in pseudogout? Large joints are involved. That is why the question said knee, and mostly in females, large joints in females. Crystals that is deposition are a calcium pyrophosphate dihydrate, which are polygonal in shape and positively birefringent. So polygonal in shape and positively birefringent. Whereas in gout, they are negatively birefringent, needle shaped, and they usually involve males. And they involve the smaller joints. The most commonly involved joint is the first MTP joint. And now the last question is a pretty standard anatomy question, which is basically asking the origin and insertions of the muscle. But let's just discuss here. A 19-year-old athlete was training. While doing hyperextension exercise, he felt a sharp pain in the shoulders. His trainer suspected avulsion of the long head of triceps. So question is telling you the muscle. From which side was the muscle detached? So long head of triceps is in question. So supraglenoid tubercle of the scapula, infraglenoid tubercle of the scapula, deltoid tuberosity, shaft of humerus. What is the answer? Straightforward question. Triceps has three heads, right? And where do they originate from and where do they insert? If you know that, you know the answer. So the long head, the lateral head, and the medial head. Long head is in the question. It originates from the infraglenoid tubercle of the scapula. Where does it insert? Olecranon. Median and lateral head, both of them also insert at the olecranon. So all insert at the olecranon. And where do they originate from? Long head originates from the infraglenoid tubercle of the scapula. Lateral head originates from the posterior surface of the humerus, but where? Superior to the radial groove. And the medial head, again, posterior surface of the humerus, but inferior to the radial groove or the spinal groove. But all of them insert at the olecranon, right? All of them insert at the olecranon. Here the patient has pain at the shoulder. That is why we are talking about the attachment at the infraglenoid tubercle. But if the triceps avulges from the olecranon, the patient will have pain at the elbow. Simple, straightforward, right? Now, in the comment section, you can ask me any question, or any doubt you have regarding these questions, or if you think the options were not accurate or there was some variation in the question, so we can discuss in the comments. The whole objective here is for you to learn. Discussing previous year questions helps us build concepts that can be tested yet again on the exam, which again proves key questions usually come from these standard topics and they will be framed slightly differently. So every year, every time they used to ask about ankle injuries, they used to talk about inversion injuries, anterior talofibular ligament. But this time they asked about eversion injury, right? So feel free to ask questions in the comments, or you can reach out to me on Instagram. My handle is the Bone Teacher. I will try to answer your questions, not only subject related, but hopefully a preparation related as well. So I wish you all the best. I will see you on the other side. Bye-bye.